Hello. Uh, can you hear me okay? Yeah. Um, so I'm sorry for I've changed something on my slide, and I think the staff are now trying to get the right version. Hopefully we'll be back soon. So I'm very pleased to be back in the US, but especially in at UCLA. It's been I think 3 years. So last June, the last time I was here in June 2019. It's just before the our turmoil time is the COVID-19 epidemic, and now everything is back almost to normal. So it's a great pleasure to be here. And also, I also want to thank the CHIPS and CBAM, especially Professor Chapter for the invitation. I'm sorry that the SIP is not able to joining us today, but I think that we have discussed a lot about the presentation today, and I also want to thank all of you for coming here in person, but also for those who are attending online. I think that you are all very busy, and some of you have not returned to the office regularly, but showing up here is means a lot to me. Thank you. So let me see if they can change the. Okay. Is that okay? Sorry. And here we go. Okay. And I also want to thank my colleagues from Vietnam, also mentees from Vietnam. And we are very proud that two of them, Dr. Nguyễn Bích Diệp and Dr. Phạm Quang Lộc, graduates from UCLA School of Public Health from the Department of Epidemiology. And since they returned from in Vietnam in early 20, I think they have been very involved in many of our efforts to scale up the methadone take home, Dr. Diệp, and also in our effort to address the epidemic in other university and also in the country level. So that's the and thank you all again. So let me first disclosure. I have no conflicts of interest to disclose, but I am grateful for the support from many NIH grants, and many of them are also working with our colleagues here at UCLA. Dr. Chapter, Dr. Klausner, Dr. Lin, and also the previous D43 that we had the support with Dr. Lee, who are present here. And also I have two projects that are now funded by the Vietnam Ministry of Health, one looking at the vaccine COVID effectiveness, COVID vaccine effectiveness, and also another project looking at the COVID-19 health workforce that are touching on some of the issues that I'm going to talk about. Just to give you an overview of the topics that I'm going to cover in my talk, I'll first give overview of the COVID pandemic in Vietnam and how we have responded to the epidemic in the past 2-3 years. And also during that time, how we scale up the OUD treatment during the same period. And then I will discuss some of the responses to support the OUD treatment during the surges, different waves of the COVID pandemic in Vietnam, especially in two cities where we are working on. And the STAR-OM study, for those who are not familiar with that, it's actually the grant that I have with Dr. Chapter that I will explain later on. And I will discuss some of the impacts of the COVID-19 on our participants in the STAR-OM study, which also could be representative for many of the methadone patients in Vietnam. And lastly, I will draw some lesson for service delivery, but also for research, some of the research question that I hopefully we can work together in the future to address. So let's first talk about the COVID-19 epidemiology in Vietnam. And here you see that I draw some comparison to the US. I know that it's difficult to compare because of many reasons, but let's try. So up to now, we have about 11 million cases in Vietnam as compared to about 90 million cases in the US. And given that number of cases, the raw number, we are ranked about the 12th country in the world. But if you sort of comparison per million population, then we rank about 104 in the world, over 227 countries. In terms of deaths, the US have are now about 1 million deaths, right? 90 million cases. We have 43,000 deaths, and the case fatality rate and also it's quite high, but the case the deaths per million population is in the somewhere in the middle. In terms of vaccination, there's been more than 200 million doses that have been implemented or vaccinated in our population of about 100 million people. So it means that on average, everyone in Vietnam are now so-called fully vaccinated for 2 doses, right? And so look at the different waves in our country. If you look at the graph on the top, right, this is the new cases per 1 million. And the red line is the US. The sort of green line here is the Vietnam. And the dark, the sort of the black is in the world, right? We see that if you look at the number of cases, the US was hit quite heavily in the summer of 2020, beginning of 2020, but also the summer. And then in the fall and winter of 2001, right? And again in 2020, and then again in the fall 2021 and the winter of 2022. That's the US on the red. In Vietnam, we were, because, sorry for the graph, that's because of the scale. You see that the Vietnam were most severe hit during the summer of 2021. Right? And of course, with the Omicron and also lifting some of the strict measure that I will describe later, we see again a surge in the COVID-19 cases in the beginning of 2022. But in terms of deaths, we didn't see many deaths up until the summer of 2021, and lasting until the end of 2001. And then the number of deaths actually going down. But in the US, as you all know well, more than I do, the number of deaths actually going up and down following different surges in the US. In terms of the vaccine doses, the US was actually ahead of Vietnam for the most part, up until around the end of 2021, right? But by the end of 2021, we were able to catch up with the US in terms of the number of vaccine doses introduced per 100 people. And by now, we actually surpassed the US in terms of the number of vaccine doses introduced in the population. And that has a lot of impact on the things that I'm going to talk about in the future, in a few minutes. We have different waves of the epidemic. in 2020 was pretty limited in few provinces, some provinces in the northern part of Vietnam. And then for the most part of 2020, we observe also in a very limited scale. But starting in 2021, that's when the Delta variant hit. You may remember. That was when we were all over the country, starting in September, after in May, April 21, all over the country. It's according to the graph that I show here. And also since the Omicron wave, we are now observing cases in all over the country. So in summary, we see that as compared to the US, Vietnam, for the most part of 2020, we were not, in terms of the scale of the epidemic, the cases as well as the deaths, we were not as affected as in the US. But since starting from the end of 2021 and also at the beginning of 2022, we also similar surges, but a less number of deaths. And also the vaccine, we are now surpassing the US in terms of the doses of vaccine introduced in the population. So how we have responded, and I think the response is very important. The picture, the epidemiological picture that we saw earlier is mostly the result of the government responses to the epidemic. Before 2020, the government introduced, as I mentioned earlier, it was the epidemic only appear in a few areas, right? And already the government introduced a lot of strict measure by different degree of the government. And for example, social distancing, partial lockdown, or even full lockdown in many of the provinces, some of the provinces that were hit in 2020. And then for the most part of 2020 and up until September 21, you see that the even more provinces were affected. And by that time, we didn't have vaccine up until late in the middle part of 21. So the government even introduced even more draconian measures to keep the epidemic in check. If you look at this is the picture that some of you who have been to Hanoi. This is like Times Square in New York City. I don't know how to compare that to Los Angeles, but there's nobody, right? It's because of the total lockdown of Hanoi during that time, and it was but as you could see that thanks to that measure, we saw the number of cases and the number of deaths was much lower than what could have been, right? But then after October 21, as our number of vaccinated people have the vaccine coverage have increased, the government has relaxed the many of the rules that guidelines that they implemented earlier. For example, now in the past, all of the cases were treated either in hospital or in a special treatment centers, so they were not allowed to stay at home. But starting in January 21, right? That's when. Sorry, this is probably wrong. That's starting in 11 November 2021. The government started to allow the COVID cases are treated at home because now we have more vaccine coverage, and we also there's more capacity to treat the cases. And also at that time the government asked all of the close contacts to stay in quarantine at home for at least 7 days. But from April to now, you see that there's a lot of debate about whether we can sort of downgrade the COVID-19 no longer as a top tier class 1, class A, we call class A infectious disease that needs special measure. But now because of the vaccine coverage, so we are considering it as class B. And many of the services like shop and restaurant, now they open regularly, and there was no concern about the temporary lockdown introduced by the government. So in summary, at the beginning of the epidemic, there was a lot of stringent and very harsh measure to keep the epidemic in check. And it actually also affected our patient, affected our methadone patient. And then from the end of 2021 up to now, the government are relaxing a lot of the measures that were introduced earlier. So, so that's the overview of the epidemic in Vietnam. So let's go to the opioid use disorder treatment in the country. And many of you are familiar with this graph already. In 2020, I mean, this is the number of methadone patients, right? The yellow bar is the number of methadone patients that are in active treatment in the country. And by the end of 2021, we have about 52,000 patients who are on methadone. And the number of clinics are increasing. But if you compare to the previous years, the number of patients seems to be leveling off and a little bit lower than what was in the beginning. And by the end of 2021, we already have 2,000, in addition to 3,343 clinics, we have also 244 dispensing sites. And these are the very important facilities and infrastructure for us to respond to the COVID epidemic. The MMT dispensing site now at the community health center level and started to introduce in 2015. And then also we introduced the buprenorphine treatment in 2019. And here's the number of, as I mentioned, the clinics, the main clinics, right? On the left-hand side of your slide, you see that the geographical map of where different clinics are. But also we have 244 dispensing sites, mostly at the commune level, at the community health centers. And here's also the map. And you see that most of the dispensing sites are in the mountainous areas, in the border with Laos, PDR, or China, and also in some of the more rural areas in the south. And here's the buprenorphine treatment. We started the pilot buprenorphine treatment in 2019, but unfortunately it didn't pick up. And actually, the new government policy is that they will keep the number the same, but not increasing in the next few years. I think this is the kind of decision that unfortunate that we, although the pilot started very early, but now the decision is that we will keep the number the same. But we have about, if you look at the different by government statistics as of the end of 2021, we have about 200,000 people with SUD, and most of them, right, half of them are using heroin or some kind of opioid product. But now we are seeing more and more of amphetamine and also other substances. So if you use the denominator as the number of opioid use disorders calculated by the government, we have about, if you add both the methadone and the people who are on methadone and on buprenorphine, we have about 70% of our people with opioid use disorders who are now in treatment. Of course, whether you could debate whether this number is believable or not, or maybe underestimate of the number of people who have opioid use disorders. But I think that the coverage, in terms of the coverage, we have been able to do a pretty good job in terms of scaling up, especially the methadone clinics, but also the dispensing side to increase the coverage. Okay, so in the midst of the COVID-19 epidemic, at the beginning of the epidemic, the government started the initiative to support and with the support from Global Fund and UNAIDS to start the methadone take home. And this is independent. I have to emphasize, this is independent from the response to the COVID-19 epidemic. Because if you remember earlier, during April 21, we were not affected as much, right? So this is an independent effort by the government, and it resulted from the concern that many of our patients, especially in mountainous area, they drop off from methadone treatment. Right? So they started the pilot in 3 provinces. One in the city, and 2 other in the northern part of Vietnam, which is in the mountainous area. And then from May this year, they cover all the clinics in these 3 provinces, and also added 3 more new mountainous provinces. And the plan is that by 2023, beginning of 2023, the government will scale up the methadone take home in the country. At this stage, the eligible criteria is very stringent. You can read, I don't have to read here. There's a lot of criteria, condition that you have to meet in order to enroll in the methadone take home program. And if you look at this criteria, most of the patients actually are doing pretty good, right? If they are unstable, they don't have any positive urine tests, is illegal drugs in the past 2 months, and so on. So these are all pretty stellar patients in the clinic, and then they are selected to enroll in the methadone take home program. And even then, they are only allowed to take a maximum of 6 doses per time, which means that 1 week, right? Every 1 week. Recently, they have relaxed to 10 doses, but still, it's nothing compared to what you have done in the US or other countries. And this is a very interesting effort by the government. They want to introduce the methadone take home, but they are still quite concerned about the diversion and concerned about other problems that methadone take home could bring. And here's the result of the pilot take home in 3 provinces, in Haiphong, which is the city, the port city, and 2 provinces in the northern part of Vietnam in the border with China. In the 23 clinics, we screened about more than 3,000 patients, but 42% of them met the criteria. You see that as I mentioned, it was so stringent, it was so hard, so difficult, that only 42% of the patients met the criteria for methadone take home. And then not all of them enroll. Many of them actually were not interested because they said that I live very close to the clinic. I want to go to the clinic rather than bringing the methadone home, for example, right? And then by that was starting in September 2021, right? And then I think that this is starting in April 2021, and then by September 21, there's about 93% of them stay in the methadone take home. It means that there's still few people between April to September, they drop off from the methadone take home program, even though they were doing very good before, even though the government give them some preferential treatment, but they still don't want to enroll in the methadone take home program. So that's as some of the reason that I have explained earlier. And here's the graph that compare those who enroll, still keeping enrolled in methadone take home, and those who drop off from the methadone take home. And we see that the number of people who missing the dosage are much higher, much higher among the people who drop off from a methadone take home program. Right? And here's the number of missing rate for the dose missing rate for the patient participating in the program. And we extract the medical records of the patient, and starting here is when they started to take home. And you could see that before the enrolling in take home, they quite a number of percent of patients miss at least one dose per month, right? But after the methadone take home, clearly there's a very important impact on the percentage of patients missing at least one dose per day, one dose per methadone per month, right? And you see that the dose, the missing dose is actually going down, and it shows a very clear impact of the methadone take home program on the adherence of the patient. And patient, many of them appreciate the methadone take home because they now can enroll in the work more regularly than they were before. So as we know, now I have described the COVID epidemiology in Vietnam. I have described the situation of the opioid use disorders in the country. In short, there's a lot of foundation that have been built when the COVID-19 epidemic hit the country. So let's look at some of the responses of how we have responded. Just briefly, we know that from the literature, we know that there's a lot of challenges for the OUD treatment during the COVID-19 epidemic, right? For example, disruption of services because of the decrease in staff availability or because of social distancing. And also there's a longer waiting line at the clinic for the screening processes, right? And also the disruption of supply as well. And also one of the challenges during the epidemic is that there's a very limited services for mental health and other comorbidities. Right? And there's been quite a number of efforts to minimize the impacts of the COVID epidemic on the OUD treatment. There's a new delivery mechanism like home delivery or mobile van delivery. There's a loosening of policy. I know that in the US, the SAMHSA, allowed to take home methadone take home for up to 28 days. And then also allowing the pharmacists to prescribe buprenorphine and also dispense buprenorphine, right? And then also emphasizing the urine testing in order to monitor patient. Some of the measures that also using telehealth and so on. So what happened in Vietnam? There was two very important guidelines that was introduced by the government. And the first guideline was in May 2021. You could see that as I explained earlier in the epidemiology, for the most part of 2020 and early 2021, there was very limited impact of the epidemic, right? But from April 2021, as the government saw that there's now more number of cases and widespread all over the country, what the guidelines introduced some new action. One is that there was no counseling was allowed. Second is that the reduce of the examination frequency. In the past, the doctor usually introduce the examination on the patient like every 2 weeks, right? But now only every 2 months. That's another measure that the government require. They also require the methadone clinic staff to deliver methadone to the hospitals or to the quarantine centers where COVID-19 positive patients are treated or are kept in quarantine. So this is a very, as you could see, that this is a very interesting measure asked by the government, that now the methadone clinic staff have to bring methadone to the hospitals, to the quarantine centers. And also later on is the home delivery. It means that the staff, they have to bring methadone to the home of the patient, bring the methadone closer to the home of the patient. And then in September 29, 2021, after the very severe surge in the south, especially in the southern part of Vietnam, the government introduced additional guidelines. Right? And now still they keep the delivery, but at the same time they allow the take-home doses, but decided by the clinical director of the methadone clinic. This is the, so as you could see that this is independent from the methadone take-home program, right? Introduced by the government earlier. There's a less criteria, right? So patients have to be at the maintenance phase, and then they allow the maximum of 7 days per time that you can take the methadone home. And also they require the methadone staff to monitor very closely the way the patient take their dosage, right? By using some form of social media or some other platforms. So you could see that the government is as the epidemic evolved, as the epidemic took toll on the patient and on the general population, the government is relaxing the way in which we responded, right? But actually that's the guideline of the government, but it varies among cities and among locations depending on how severe the epidemic was. Okay, and here I compare between Hanoi and Ho Chi Minh. If you look at this on the upper part of the cumulative cases, and the part below here is the cumulative deaths. If you look at Hanoi and Ho Chi Minh City, actually the number of cases by June this year, the number of cases in Hanoi was much higher, but the number of reported deaths, at least those who were reported as dying because of COVID, was much lower than in Ho Chi Minh City. Right? And the reason was because the Ho Chi Minh City was hit very heavily. This is the right. The highest number of cases was sometime around September to October of 2021. Right? And remember, at that time, we didn't have vaccine. We didn't have vaccine at all. Right? But the number of deaths in Ho Chi Minh City also increased at that time. And now it's starting to level up, but it was very high during the second part of 2021. Why? I mean, sorry, here in 2021, but in Hanoi, the number of deaths was pretty stable, and right now this is the total number. And because of the different epidemiological features of different cities, each city chose a different measure to respond to the epidemic, to address the substance use treatment. Here, some of the measures that prescribed by the government, by the central government, national government, were used in the both cities. As you see, that patients who are treated with COVID-19, the methadone clinic staff deliver methadone to hospital weekly, and then the hospital staff dispense methadone to patients daily. It was the same for both cities, right? And also also delivered to the quarantine centers. But in Hanoi, we used the community health centers as a central point to deliver methadone to patients. So the methadone staff bring the clinic, bring this methadone quickly to the community health centers, and the community health center staff deliver or ask the patient to come to community health centers to take the methadone daily. That's how we did it in Hanoi. But in Ho Chi Minh, the methadone staff play a very important role in even delivering the methadone to patients on a daily basis. And also in Ho Chi Minh City, in Hanoi, we didn't implement the take-home, right, at all. But in Ho Chi Minh, they started to implement the methadone take-home as allowed by the government during the August and September period, when the whole city was in lockdown because of the number of cases was so high. How am I doing? Okay. So so you see that what I'm saying is that even though the different measures are prescribed by the government, the different cities took on different measures, a little bit different measures in order to address the epidemic. And here's the methadone take home in Ho Chi Minh City. There was they had about 23 clinics with more than 4,000 patients, and all of the and at that time, I mean the statistic of the Department of Health showed that 22% of them were experienced some form of quarantine because they were either tested positive or they were close contact with someone tested positive, right? And then 12% of them were actually tested positive themselves. So, so it means that these are the people who actually needed the methadone delivered to either hospitals or in the quarantine centers. When the methadone take home was allowed, most of the clinic were enrolled, and 80% of the patients actually benefited from the methadone take home. And the government also reported that there was very few diverse incidents as a consequence of take home, right? So this is a very, it alleviates a lot of the concern previously by the local authority that once the methadone take home are allowed, then there's a lot of issues, right? Then this is a very, very strong statistic to show that there was not a problem. And here's some of the pictures that I just show you. So the methadone clinic staff, they prepare the methadone take home dosage in a bottle like this for patient every day. So each day is one box like this, and they manually, I mean, prepare for hundreds of patients in their clinics, right? And here the staff deliver the methadone to patient, I mean to on the motorbike, bring themselves, okay? And here's, you see that in Hanoi, the patient go to the community health centers as a sort of small setup, separate from the centers so that they can take the methadone in the community health centers or in the location chosen by community health centers. And here's the quarantine, right? This is the barrier for the quarantine area, and patient go to the what do you call it, barrier, in order to take the methadone dose delivered by the methadone staff. So you see that these are the type of the things that happening during the 2021 and early 2022 in Vietnam. So how that have some impact on our study? This is just a brief introduction of our study. We are now like halfway through our recruitment, and you could see that the COVID could have impact on different steps in our study. For example, at the screening stage, at the motivational interviewing stage, at the group education, right? And also at the matrix model, where also most of the activities are in group format, right? So if you look at the study that we are implementing, COVID-19 could have impacted many of the steps that in our study. But fortunately, we have implemented many of the measures to protect both the research staff and the patient, and also the clinic staff who are involved in the study. For example, the postponing the data collection during lockdown. Unfortunately, the lockdown in Hanoi was short, so we were able to implement the data collection immediately after the short lockdown. We also implemented telephone-based interviews. We use face shield and other protective measures when we do face-to-face interviews with the patient. And these are for the staff. We ask them to hold a smaller group session, or even deliver the individual intervention of the same content as the group-based intervention. And also for patients who are in quarantine or in treatment, we resume the intervention if they have like more than halfway through the sessions. But if they were less than halfway, we restart again the intervention. So these are some of the measures that were introduced in our study. And you could see here some of the pictures. This is the shield that we installed in the methadone clinic at the time when the epidemic hit those clinics in order to implement the study. Here's the group session that were held. It's a smaller number of patients. And here's also the shield that were used by the interviewers. And here's we conducted the Zoom based monitoring of the intervention with our clinic staff. So in short, we were pretty much trying to do as much as we can to keep the study and the intervention going. So here's some of the data we collected from the patient that we have enrolled so far in the study. You see that there was about less than 80% of our patients were not infected at all with the epidemic, with the COVID, or not suspected. And about 20% of them were infected with the COVID-19, right? And here's the different, at different months, the percentage of patients out of the 307, percentage of patients were infected. And you could see that it also reflects the epidemic in the country. Most of patients were either infected during the surge in late 2021 or in early 2022, okay? And I think that there was a lot of the measures that were introduced by the community level, by the government, also at the clinic, were able to keep the patient uninfected. And after the end of 2021, so mostly thanks to the vaccine. And here's the different kind of symptoms that our patient experienced. And most of the most experienced symptom was weakness and tiredness, right? And it was like 8% of the patient didn't report any symptom at all. And here's the vaccination. This is interesting data among our patients. You should see that more than 60% of our patients have received three doses, right? And even smaller number have received 4 doses. And these are different type of vaccine that they receive: AstraZeneca, Moderna, Pfizer, and even the Chinese made and also the Russian made vaccine. So it means that the government was trying to do everything they could to increase the vaccine coverage among the population. And the methadone patient, the coverage was also similar to the general population. And here's how they reported on how the COVID-19 impact their life. And I would say that most of them reported the financial aspect and mental health aspect was how they were most affected. And this is not a surprise, right? I mean, that's generally the case. And as you could see that many of the patients who are on methadone are already poor, from the poor family. So the COVID-19 actually brought much greater burden on this patient. And this is something that I think we continue to study the impacts of post-epidemic. And here's the report on how the COVID affected the treatment. I mean, the responses affected their treatment. And this is interesting. Like 8% of them said that the fact that the methadone were brought to their home, closer to their home, actually reveal the identity that they didn't disclose before. And I think this is very something that we have to try to address in the future. So what are some of the lessons learned that we from the both what we observe in the two cities and also what we observe from our study? I think that the enormous efforts have been implemented from all levels, right? The national, the provincial, the clinics, even the patient and their family, and in order to ensure the impact is as limited as possible, right? So you could see that the not many patients actually missing many methadone doses. I think that the methadone take-home pilot, independent from the relaxation of methadone in Ho Chi Minh City in 2021, I think they are the excellent learning opportunity for us to learn how we can scale up the methadone take-home in the future. And I think that we are continuing to draw lesson and to write reports on these issues. I think that the right now, as I mentioned, both the vaccine coverage among methadone patients and the national general population are very high. And I think that it's a very good foundation for relaxing a lot of the measures that we have taken so far. And lastly, I think there should be something learned from how we could implement the COVID-19 vaccination so rapidly, so that we can draw lesson from that for other services that are needed by people who are in treatment. So what are the some of the research questions that we learned from the epidemic? I think that the burnout is a huge issue. You could see that the staff was invested a lot of time and efforts, right, into helping the patient. So I think that the first question is, there are some of the cost-effective implementation strategy for the methadone take-home that could alleviate the burden of the staff. There was like 4 or 5 staff in each clinic, and now they have to take care of that many patients. They have to do all kind of extra work. Right? So what are the strategy that we could help them? We have to address the issue of burnout and mental health consequences. And I think this is something that both in terms of their training, but also in terms of how we could deliver the training to the staff in order to address the burnout and mental health. I think that one of the lessons we learned was that there was limited counseling and other in-person services during the searches, and this is something that we want to minimize in the future. We don't know what's going to happen later this year or next year, but we can't continue to stop counseling, right? We have to somehow deliver it. We have to somehow make sure that the patient receive the in-person services. And this is something that we have to, some of the either telehealth or otherwise, that we could do this. And last but not least, we see that about 20% of our patients were infected with COVID-19 at this point, and many of them have symptoms. So what would, and also the impacts in terms of socioeconomic and mental health was not small. I think that the question is, what are we going to do? What kind of challenges that would our patient would face in the post-COVID epidemic phase, right, including long COVID and other issues. So these are the some of the questions that I hope we'll be able to work together between HMUs, faculty and UCLA faculty in order to address some of the questions that are maybe not only relevant for Vietnam, but also relevant for the US and other parts of the world. Thank you for your attention. I'm sorry that I'm running a bit too long, and I hope that you will stay healthy during the summer, enjoy your summer, and I hope that, and thank you very much for your collaboration and for your attention. Thank you. What happened? Can you repeat? Yeah, yeah. I didn't get the second part. Oh yeah. So can you talk about the your view of the COVID test? Yeah, yeah. No, I think that clearly there's been study that show that the public trust in the government and also the government transparency in terms of the response has a huge impact on the number of cases, right? And also number of deaths, as well as the vaccine rollout. And I think that the in Vietnam, one of the advantages of our country is that once the government decide to do something, and they are able to mobilize the whole political system to complete to implement that. That's right. So I think that vaccine rollout is not is not is part of that. Is something that's have been implemented and have been introduced very forcefully by the government. And I think that there's a lot of both the issue of trust, but also the issue of need from our patient. You see that before if you look at the epidemiological picture that I described earlier, before the vaccine, there was a lot of deaths, right? Especially in Ho Chi Minh City, right? And that actually have a lot of impact on people. So as soon as vaccine became available, many people sign up for it. And that I think that's so the issue of trust, the issue of fear, the issue of many other things that have led to that success in vaccine coverage. Yeah.
Among the ones who were really although media was saying, oh my God, everyone's saying it. But I'm wondering, so thought actually there was probably mitigators or people that had fallen off treatment. We seem to have, depending on people who were in treatment. Do you have any idea in Vietnam if you saw also overdoses among people out of treatment that were in not on methadone, but were actually, or any of the similar overdose increased rates that we saw here?
Yeah, I think that's a great question. I think as you clearly pointed out, that the data that I have presented here, and also the some of the things that I draw out, mostly from population who are in treatment, right? But I also mentioned earlier that 70%, at least to who are known to the government, right? At least 80% of them are in treatment for the opioid use disorders. There may be a lot less for the other kind of substances, especially stimulants. So the answer to your question is we don't know. I think that's very important issue to understand that of the 20% who are not in treatment, especially OUD, who have experienced overdose during the epidemic, right? And I think that the way in which people used in the epidemic actually make them much more susceptible, much more vulnerable to overdose. They use alone, they can't use with friends and so on. So I think that's something we continue to learn about. Yeah, I think that the stigma is still a big problem. I think of those who are in treatment, as you should see that many of them still hide the fact that they are opioid users. They hide the fact they are in treatment, right? So the home delivery was in a way actually revealed the identity. There was 8% of our patients in the study said that methadone take home reveal identity, and that's something we have to address. And I think that I suspect that of the 30% who are not yet in treatment, stigma actually play a very important role, right? So I think one of the challenges that we have to study and also to address is the issue of stigma against the substance users. Stigma both at the level of internalized stigma, but also at the community level.
Since there's been some generally pretty good success to take from there's also need to relax requirements for the 3D provinces.
I hope so. I hope so. I think that our team have been asked by the government to evaluate the methadone take-home program that has been introduced in 6 provinces, right, in this year. So Dr. Ziap, actually, one of the UCLA graduate, is leading that study. And hopefully by the end of this year, we'll have a report to show using both the data from the methadone take-home in Ho Chi Minh City and also the methadone take-home in 6 provinces in the north to show that there's a lot more that we could do, right? But at the same time, the government we have to address the government concern about the safety, not only for the patient, but also for the population. How do we address that? We also have to address the question of how to help the methadone staff to undertake the task asked by the government for delivering home, doing the home delivery or doing monitoring without making even more burdensome for them, right? So this is the question that I referring back earlier. How are going to reduce the burnout and the pressure on the methadone staff as we expand or respond to the epidemic? Yeah. Thank you.
Any other questions from the all right. Thank you so much for this.
Thank you. Thank you so much for your attention, and thank you.